Evening, all the aspirants present here. Today's topic is respiratory medicine, and the faculty that we have here is Dr. Vinod Jaiswal, sir. He is a consultant, critical care, Medicare at Royal Specialty Hospital, Dubai. Yes, sir, you may continue. Thank you.
Hi, good evening, everyone. Happy New Year to all. I hope you are studying well, and this year, whatever you part one, part two you want to take, hope you all will be successful. Okay, and whatever part I can play small, I'll be happy. So I think actually this is the fifth lecture. So it's a similar pattern actually, but this time topics are mixed. Before this, I was taking topic wise, but I think most of the important topics are covered. So I thought let's keep a mix of topics and see how it goes. Okay. Better you guys also answer. So, which one of the following is a contraindication to surgical resection in lung cancer?
हैं? कर लो कटो यार तो दो भाई कितनी देर में ला देगा हेलो
Hello, shall I continue? Yeah. So, any guesses? It's a tricky question. Let's look at the answer. The answer is A. Actually, is a vocal cord paralysis. Why it is so? The vocal cord involvement means that the recurrent laryngeal nerve is involved. Means the disease is already locally advanced, and this represents a T4 stage of the TNM staging, indicating that there's a direct invasion of the mediastinal structure. So surgical resection is not possible at this stage. What are the other options we had? Sorry. FEV1 less than 1.9. Actually, pre-op when you evaluate, so FEV1 more than 1 point, predictable more than 1.5 predict that the operation may be successful and patient will not require a respiratory support. Okay. So the predicted post-op FEV1 more than 40% is considered acceptable for surgery. Squamous cell is one of the non-small cell carcinoma. If detected early, yes, it is an indication of surgery. Okay, and the remaining are very obvious. Calcium and hemoptysis. Calcium is because of the paraneoplastic syndrome, and hemoptysis may be local bleeding. These are not a contraindication for surgical lung resection. Actually, we have done the CA lung, but just I included this question, which was I thought is interesting. All right, let's move. A 40-year-old obese woman presented to her GP complaining of daytime somnolence. She is asked to fill out an Epworth Sleepiness Scale questionnaire and scores 20 out of 24. Her GP arranges overnight pulse oximetry and she is diagnosed with obstructive sleep apnea. Alongside weight loss, what other intervention is appropriate in this setting?
CPAP B.
CPAP B. Why not BiPAP?
For airway to remain patent, you require continuous positive airway pressure. It is not a Y-level positive airway pressure, which is required in COPD and in carbon dioxide retention.
Right. So, yeah, so it's a severe obstructive sleep apnea because the score is 20. There are other scoring systems also which I will going to tell. So answer is correct. Overnight CPAP with continuous positive airway pressure ventilation. Let's look at the other options also. So yes, the IFAS score is high, and the SIGN guidelines, sign guidelines recommend that any sleep apnea has to be weight reduction first, and then overnight CPAP, or even the daytime also. BiPAP not routinely, but it can be used if some type 1, type 2 respiratory failure along with is present, can be considered. Other options like mandibular advancement should only be used who cannot tolerate CPAP and which have mild symptoms. And the surgery, generally, randomized control trial has shown that evolopalatal pharyngoplasty is not effective. So yes, CPAP, weight reduction, and CPAP is the most standard treatment for moderate to severe OSA. We'll do a little bit uh, study on the OSA. I think we don't need to go into detail what are the signs and symptoms of OSA. Everybody knows, associated with obesity, many other factors, sleepiness, somnolence in the day, napping time during the day, and loss of energy. So there are. This is one of the questionnaire, but there are many other questionnaires people are using in the clinics. So this is one of the questionnaire which you can ask, and accordingly scores are given. There are calculators available which gives you the score. Okay, so do you feel sleepy during the day? Daytime sleepiness is a problem. Is it difficult to keep your eyes open at the daytime? Do you struggle to stay awake during the day? Do you take naps? How often and how long do you nap? Do you fall asleep at times when you don't want to, like watching movie, reading a book? Very common questions. These questions about sleepiness. Other questions about tiredness, fatigue, and low energy. Do you lack energy to go about your daily activities? Do you tire easily, sooner than others? Do you feel physically, mentally exhausted? And the questions differentiates sleepiness from related complaints. Okay. So does your problem bother you more if you sit to read for an hour or you go out shopping for an hour? Which of the following is the single most problem for you? Sleepiness, tiredness, fatigue, or lack of energy? Anyway, these questions, as for the exam, is not important, but you should know what are the questions, and in practice, you can come along such patients, so you can pull out this list and try to get a score and then see. There's another questionnaire. There's a stop bank questionnaire, which is more commonly used. There's another one is there, enhanced stop bank questionnaire, but this is commonly used and scoring is easy. So you can see that low risk, intermediate risk, and high risk of OSA. Okay, questions are similarly actually if you see, but some different. Snoring, tiredness, has an observed stop breathing, choking, gasping, pressure means in high blood pressure, body mass more than 35, age more than 50, neck size, measure around Adam's apples. Is your shirt collar 6 inches larger? Or gender, males. Okay, more common in males. So low risk is 0 to 2, high, intermediate or moderate 3 to 4, and high risk is 5 to 8 questions. This is a more definitive diagnosis, which when you screen with the clinical questions, whether the patient needs a home assessment or at clinic assessment, polysomnography you do. Okay. There are three indexes, AHI, which is apnea hypopnea index, RDI, which is respiratory disturbance index, and REI, which is respiratory event index. Okay. So when you do polysomnography, if AHI 5 to 14 per hour sleep plus one or more sleep associated conditions, or more than 15 per hour sleep when AHI is there. RDI 5 to 14 again similar. And when you do home sleep apnea or home testing, when the REI, respiratory disturbance, respiratory event index, more than 15 per hour during total recording time. So these are the diagnostic criteria for OSA. Okay. So there are criteria also which patient you should test at home, which patient you should test at clinic, So, but I don't will not go into details, may not be that relevant, but yes, it's important in a daily practice, not maybe for the MRCP. So you can remember roughly this, roughly more than 15 AHI or RDI in polysomnography or home sleep testing should rule in favor of OSA. Okay. Treatment, moderate to severe, which was our patient. So positive airway pressure therapy with CPAP. Again, the recommendation is not that great, but still grade 2C is good enough. Mild OSA, suggest CPAP in certain patients. like patient who perform mission critical work, example, airline pilot, symptomatic patients with excessive daytime sleepiness, non-restorative sleep, patient with comorbidities such as hypertension. So mild OSA with selected conditions, you should see PAP along with other measures, weight reduction, healthy lifestyle, and sleep hygiene routine, all supportive measures. Okay. Any questions on OSA? Anything you want to ask? Okay. A chest X-ray of a patient with sarcoidosis shows bilateral hilar lymphadenopathy but otherwise normal. What chest X-ray stage does this correspond to? Stage 0, stage 1, stage 2, stage 3, stage 4.
Stage 1.
Stage 1. Okay, good. Yeah, just the bilateral hilar lymphadenopathy corresponds to stage 1. Okay. Stage 0 is normal. Stage 1 is bilateral hilar lymphadenopathy. Stage 2, bilateral hilar lymphadenopathy plus interstitial infiltrates. Stage 3, diffuse interstitial infiltrates only, and stage 4 is diffuse fibrosis. Of course, other investigations you can do to diagnose sarcoidosis. Few of them are, but mostly diagnosis is clinical, so and suggested by the radiological features. So spirometry may show a restrictive defect. Tissue biopsy may show non-caseating granuloma. Sometimes this is the only abnormality you can find along with some symptoms. Gallium scan, but not routinely used nowadays. The QM test, which is they take the sample from the affected patient of the sarcoidosis from the kidney and they do subcutaneous test. But again, no longer is recommended due to concerns about cross infection. So yes, the staging is important. May ask in the MRCP exam, and how you diagnose, depending on what you should know how we can diagnose, or depending on the question and scenario you can answer. So spirometry, tissue biopsy, gallium scan. Okay, or there are some clinical features and associated mm, findings or syndromes you can diagnose sarcoidosis. Okay, so there are two columns if you see: highly probable and probable. Okay, uh, if you go in history, Lofgren syndrome, the questions can come on Lofgren syndrome also. It's an acute condition actually, and it's a bilateral hilar lymphadenopathy associated with erythema nodosum and arthritis or periarticular inflammation. So if this is present, it's classical and high probability of sarcoidosis is there. Okay, in the history, if you find another features like seventh cranial nerve involvement, renal AKI, or atrioventricular nodal block, cardiomyopathy, okay, um, and spontaneous or inducible VT because of cardiac involvement with no other risk factors. So high probable of sarcoidosis on the history. And physical example, if you find lupus pernio, which are some um, radiculopular lesions around the nose, or uveitis, or optic neuritis, or erythema nodosum. Again, these are also disease defining or sarcoidosis defining kind of physical findings. Okay, but again, if this classical is not present, other lesions like maculopapular erythematous or violaceous rash, subcutaneous nodules, quite common, scleritis, retinitis, lacrimal gland swelling, granulomas, parotid enlargement, hepatomegaly, splenomegaly, again, along with clinical features, can be diagnostic, a probable diagnostic of sarcoidosis. Imaging, as per the we have seen already with the X-ray or with the CT also we can do. So bilateral hilar lymphadenopathy, you should highly suspect sarcoid. in perilymphatic nodules. This scanning PET scans with gadolinium. Okay. Osteolysis, cystic punch out lesions, trabecular pattern in the radiograph, or parotid uptake in gallium scan or PET scan. These again are highly suggestive. Okay. Upper lobe fibrosis in CT or PET, peribronchial coughing, extrathoracic nodes, increased inflammatory activity in heart, enlargement of nodules in liver, spleen, bone. So these are also probable on the imaging, but more commonly on the lungs. Another suggestive are hypercalcemia or hypercalciuria with abnormal vitamin D metabolism. Okay. If you go other testing in probable, so reduced ejection fraction, okay, with no risk factor causing restrictive cardiomyopathy, elevated AS levels, we commonly do it, but it's, if you see it is in not highly suggestive, but it's um, supportive only probable and should be more than 50% above the normal. Okay, nephrolithiasis because of high calcium, bronchial oral lavage you can do and see elevated ratio of CD4 to CD8, alkaline phosphatase greater than 3 times the upper normal limit, or new onset EV blocks in middle young age patients. Okay. So these are the probable, highly probable and probable diagnostic criteria in support of sarcoidosis. Okay. I think I should not have any doubt about answering any questions if comes. Okay. Treatment generally there are three. Sarcoidosis treatment can be divided into three. I did not made a slide as per that, but it's asymptomatic, mild to moderate, and severe. Okay. In any of these, whether it is asymptomatic, whether it is mild to moderate or moderate to severe, but in any of this, if it is rapidly progressing radiological or clinical features, then you go with steroid and methotrexate combined together. Okay. So in general, when any type of sarcoidosis but it is rapidly progressing, so you go with steroid as well as methotrexate and then assess the response after 4 to 6 weeks. If we talk about asymptomatic patients, so there are some criteria where you can use steroids, which if the patient have these three criteria: stage 4 radiologic disease, but patient is not symptomatic, moderate to severely reduced vital capacity or diffusing capacity, or exertional hypoxemia. These are asymptomatic patient with this kind of criteria. Then you can start with steroid, and if it is rapidly progressing, then you add methotrexate. Again, mild to moderate, you start with only steroid, and if it is rapidly progressing, you add methotrexate. And in severe, if it is not rapidly progressive and it is chronic, you may just start methotrexate and then add plus minus steroids. Okay. Let's move. Next question. Which one of the following is least associated with Carter-Jenner syndrome? Male subfertility, dextrocardia, recurrent sinusitis, bronchiectasis, and malabsorption.
Male subfertility.
Male subfertility. Okay. Why not any other?
Maybe malabsorption because dextrocardia, sinusitis, and bronchiectasis are part of this.
Correct. Those three are the cardinal features. So remain with the two, male subfertility and malabsorption. The answer is E. Okay. So it is called as primary ciliary dyskinesia. It's a rare genetic disorder with situs inversus totalis, including dextrocardia. So chronic sinusitis and bronchiectasis are common. So defects in the structure and function of cilia lining the respiratory tract, leading to impaired mucociliary clearance. This is the pathophysiology. So generally malabsorption doesn't happen in this, but yes, male subfertility It affects the motility of the sperms and can cause fertility issues in males. Mm, but malabsorption in general, not due to primary Carter-Jenner syndrome. A 58-year-old woman is referred to the renal clinic with a 3-week history of lethargy and ankle swelling. She mentions occasional nosebleeds over the past 2 months. Examination reveals blood pressure of 165 by 95 and bilateral pitting edema. Urinalysis shows blood 3 plus, protein 3 plus. A renal biopsy is performed. Which histological finding is most likely to be seen? So here you have to diagnose the condition and then see in that condition how the kidney gets affected, whether it is nephritic, whether it's nephrotic, or which kind of glomerulonephritis. What do you think the diagnosis is with the condition?
Good posture syndrome.
No. Good posture. What is in good posture? Generally hematuria and some lung involvement.
Lung involvement and
Yeah, but not the nosebleeds kind of feature.
there is focal segmental glomerulosclerosis in hypertension, but here.
Correct.
Hmm.
So diffuse proliferative, membranous is nephrotic, mesangial is IgA disease. It's clearly mentioned. Nodal glomerulonephritis you mentioned already with the hypertension, which is correct.
Yeah.
Okay, let's see what the diagnosis first. Okay. The answer is crescentic glomerulonephritis. Why it is so? So the diagnosis is Wegener's. We no longer call it Wegener, but it's granulomatosis with polyangiitis. So renal biopsy will typically show crescentic glomerulonephritis, which is posse-immune necrotizing crescentic glomerulonephritis. Okay, which is shows epithelial crescents in the Bowman's capsule. All right. Other investigation is Cianca, which is anti-PR3 antibodies positive in 90% of the cases. Okay. So it is Wegener's with nosebleed, granulomas, with kidney involvement, with hypertension. Okay. It's a semi-emergent or emergency condition. You have to treat aggressively these kind of patients when they present to you with such a presentation. Okay. Let's look at the other options. What are the diffuse proliferative granulonephritis typically seen in post-infectious or lupus nephritis? Membranous nephropathy is the most common presentation in nephrotic syndrome. Okay. Mesangial IgA deficiency is a Berger disease, hallmark of IgA nephropathy. And nodular glomerulosclerosis, which is already called Kimmel-Wilson disease, characterized diabetic nephropathy, not hypertension. Sorry, my bad also. So it's in diabetic, not in hypertensive. That hypertension, I think, is sclerosing nephropathy, not nodular glomerulosclerosis. I think. All right. So these are the common presentation: necrotizing granulomatous vasculitis, affecting both upper and lower respiratory tract as well as the kidneys. So epistaxis, sinusitis, nasal crusting, or when involvement is in the upper respiratory tract, and when the involvement is in lower respiratory tract, dyspnea, hemoptysis in kidney, posse-immune, rapidly progressive crescentic glomerulonephritis, saddle-shaped nose deformity, vasculitic rash, eye involvement, proptosis, cranial lesions. Okay, there can be overlap with another kind of vasculitis, which is Churg-Strauss syndrome. Okay, we don't no longer call it Churg-Strauss. Is EEPGA, eosinophilic granulomatosis, right? So Wegener's generally renal involvement, epistaxis, hemoptysis, ANCA, vasculitis, sinusitis, dyspnea, and in Churg-Strauss commonly Pianka, eosinophilia, and asthmatic features. Okay, that's how you can differentiate between these two. Treatment slightly different. Both will use steroids. Okay. Cyclophosphamide more commonly used in vaginers. It's a very good response. In emergency, we cannot wait for the steroids and cyclophosphamide effect. So we do plasma exchange in emergency, and survival is after diagnosis just around a decade. Okay. A 60-year-old man present with shortness of breath, wheeze, rhinorrhea. On examination, you note a bilateral expiratory wheeze. These are the investigations, and uh, which drug you should avoid while treating this condition. You know the diagnosis, right? We just discussed, correct? So what is the diagnosis? All right, let's look at it.
Bronchial asthma?
No, Priyanka is positive, no? Priyanka is
C.
positive.
Hmm.
Yeah. It presents like a bronchial asthma, but it's not a bronchial asthma. Presentation is a bronchial asthma, but the diagnosis is Church-Strauss, right? Eosinophilic granulomatosis with polyangiitis. So, montelukast, which is leukotriene receptor antagonist, sometimes may trigger presentation. So, should be avoided in treatment of eosinophilic granulomatosis with polyangiitis, which is Church-Strauss syndrome. Okay, the common features are asthma, blood eosinophil more than 10%, paranasal sinusitis, mononeuritis multiplex, which is more common, nerve involvement in this one more than vaginous. Renal involvement though occurs, but it is around less than 20%, and Priyanka are positive in just 60%, whether in Priyanka was positive more than 80% in vaginals. Okay. Again, the treatment remains similar: steroids, treatment of asthma, and long-term cyclosporin. But montelukast to be avoided as it can precipitate asthmatic features. Okay. A 17-year-old male with history of cystic fibrosis presents to clinic for annual review. What is the most appropriate advice regarding his diet? High calorie, high fat with pancreatic enzyme supplementation for every meal. High calorie and high fat with pancreatic enzyme supplementation. I think it was repeated, I think. Yeah. With evening meal. High calorie, low fat with enzyme supplementation in the evening meal. Normal calorie, low fat every meal. High calorie, high fat evening meal. Which one is the answer?
High calorie, high fat with pancreatic enzyme supplementation for every meal.
Now it is very obvious. Just people only get confused with high fat because everybody thinks that pancreas is not working, so should avoid fat. But why they need high? So uh, yes, high fat, high calories because they have a lot of work of breathing, their energy requirement is more. So we need to supplement high fat and high carbs diet each meal and pancreatic enzyme each meal. It cannot be that you can avoid it one meal and then because then fat absorption will not happen if you don't supplement. There is no point in then giving high fat diet if you don't give a pancreatic enzyme supplementation. Okay. Some of the important management of cystic fibrosis is regular physiotherapy, postural drainage. Even patient himself and the or the family members can help in doing postural drainage. Deep breathing exercises, high calorie diet including high fat intake, Okay, minimize contact with other patients to avoid infection. Infection with Burkholderia and Pseudomonas are quite common in this kind of patients. Or other vitamin supplementation, panatic enzyme supplementation with every meal, and lung transplantation if it is available. And it's important to avoid infection because it's a contraindication. Burkholderia infection is a contraindication for lung transplantation. Okay. Another important therapy is lumacaftor and ivacaftor, that which is called as Orkambi. If patients who are homozygous for mutation delta F508, they can significantly benefit with this Orkambi treatment. Okay. So what it does basically is increases cystic fibrosis transporter receptor proteins that are transported to the cell surface. Okay. And ivacaftor is potentiator of CFTR, that is already at the cell surface, increasing probability that the defective channel will be open and allow chloride ions to pass through the channel pore. Okay. This can be a potential MRCP questions on cystic fibrosis management. A 54-year-old woman with a 30-pack year history. We already finished the COPD long back, I think, but I thought just to include one more question. The 54-year-old woman with 30-pack year history of smoking presents due to increasing breathlessness. A diagnosis of chronic obstructive pulmonary disease is suspected. Which of the following diagnostic criteria should be used when assessing a patient with suspected COPD? FeO1 more than 70% of predicted value plus FeO1 less than 60, FeO1 less than 70 plus symptoms suggestive of COPD, FeO1 less than 70 plus FeO1 less than 70, FeO1 less than 80 plus FeO1 less than 60, FeO1 less than 70 and FeC more than 70. Which is the answer?
C. FE1 less than 70% and ratio less than 70%.
Okay. Any other answer? This question everybody should be able to answer. It's a very easy and it's a diagnostic question, diagnosis of COPD. What we look at? We look at the ratio, no, first, correct? And then we classify according to the FEV1. Actually, it's a very easy question. There's only one right answer. It's only one option they have given. So answer is B. It's easy to confuse, if you don't remember how we diagnose COPD, more or less look similar and tricky, but it's very easy question. Okay. So what COPD requires is COPD symptoms: cough, breathlessness, sputum production, seasonal bronchitis, wheezing, okay, and demonstration of airflow obstruction on spirometry. So FE1, FEC has to be less than 70% or 0.7. This is the diagnostic criteria. And then you establish the grade or severity according to the FEV1, correct? But FEV1 is never a part of diagnostic criteria. Another question can be what can be used to monitor progression of the disease. So again, there also answer comes FEV1, not the FEV1 FEC. For diagnosis, it is FEV1 by FEC, which should be less than 70%. And for the progression monitoring treatment to therapy, you always follow FEV1. All right. So B, FEV1 FEC ratio less than 70 plus COPD symptoms is diagnostic of COPD according to the NICE guidelines. This is a classification. That's why I included this chart. Okay. Post and that too even post bronchodilator. Okay. So FEV1 by FVC less than 0.7. If you see all the right columns are less than 0.7 and the severity is diagnosed according to FEV1 of the predicted. So more than 80% stage 1 mild symptoms should be present to the diagnosis of COPD in this patient. Then 50 to 79 is stage 2, 30 to 49 stage 3, and less than 30% is very severe, which is stage 4. Any doubt here? Okay. Which one of the following would cause a fall in carbon monoxide transfer factor? Good posture syndrome, left to right cardiac shunts, hyperkinetic states, exercise, anemia. If
Anemia.
you know anemia, why anemia? Why not others? Why not good posture?
Because
The answer
decrease in TLCO means lungs are less efficient at transferring carbon monoxide from the alveoli to the blood.
Hmm.
So maybe it is an interstitial lung disease, emphysema, pulmonary hypertension, or anemia.
Okay. Your logic is right for anemia, but not for the other reasons. Okay. So, as you said, that hemoglobin has to carry the carbon monoxide also, correct? Outside.
Yes.
In anemia, hemoglobin itself is less. So, TLCO will be less. Okay. When you look at the other options are very simple and easy. You can rule out by that. Good posture, there's already hemorrhage blood there in the lungs. So again, hemoglobin is more available. So more binding of carbon monoxide. So TLC will be high. Left to right shunt, hyperkinetic state, and exercise. All these will increase pulmonary blood flow. So TLC will be high. Anemia also is a severe, it should be hyperdynamic state, can increase cardiac output and pulmonary blood flow, but hemoglobin itself is less. So TLC will be decreased because even if you increase the blood flow in anemia or hyperdynamic circulation, but hemoglobin is less, which is fundamentally required for TLCO, right? So it is a rule out question kind of, if you know a little bit physiology. So anemia is the right answer. So anemia results in fewer red blood cells and therefore less hemoglobin being available to bind with carbon monoxide during the test. The TLCO measurement depends on both diffusion of carbon dioxide across the alveolar capillary membrane and the amount of hemoglobin available for binding. So reduced hemoglobin leads to a lower TLCO value. Good posture syndrome typically causes alveolar hemorrhage, which would actually increase the TLCO due to presence of additional hemoglobin in the alveolar space available for carbon monoxide binding. Rest all increase the pulmonary blood flow as we discussed, and the TLCO is high. Oh, sorry. Done for today, guys. Again, it was a small time. I didn't have the time to prepare much slides today. After the new year, a lot of busy work. Any doubt? Any questions for the? I think we can take one more class on respiratory and then wind up. Any topic you want to cover specifically, I can take that next time, or we can continue like this. And I will try to avoid the topics which already being covered. Hello? Anybody, anyone want some different topic next time? May I ask what you guys are using for question bank?
Past test, sir.
Past test. Okay. Any question bank given by the Farz Academy?
So there are the mock exam conducted in the portal.
Hmm. Okay, how do you find this question which I am giving? Easy, simple, difficult? Should we use more difficult questions? More description on the topics? Any suggestion that I will try next time?
These are the more practical questions which you have discussed today.
Okay.
Because
So
the
this is
question,
good also because just reading a topic, it doesn't imbibe much, but giving a question and then explaining the topic is more, I think, easy for the students to take up, sir.
Okay. I'm just going through the topic on respiratory, what is left. If you want any particular topic, next time I will cover those. So lung anatomy, physiology, should we cover? I don't think there are much questions on that. As disease of the lung, we have covered. Infections, we have covered. Occupational, I think also we have covered, right? Tumors, we have covered. Interstitial lung disease has been left, but it's not much in interstitial sarcoid we have covered. Then ILD is nothing much in ILD, not much in ILD. Then vasculitis, a little bit has been covered today. And then miscellaneous fluid diffusion, pneumothorax, sleep apnea we have covered. ARDS left, ventilatory support. Okay, let's see. I'll try to close in the next all the remaining topics and we will conclude it. Thank you guys. Thank you for your time. Sorry being again it's a small session. I know that your time is important. But let's see next time we will wind up more and try to cover more. Okay. BMJ examination question is useful for MRCP part 1. No, I have no idea what is BMJ examination question. But I think past test is good enough. There's some RC medicine, RX medicine, something other question bank is also there. Then the past medicine is there. But anyone you stick to it. And the most important is the last 1 week of exam or last 2 week, you should revise it and try to solve as much question. But revision is very important along with questions and topic. Okay, guys, thank you.
Thank you, sir.